today. I'm Becky Royer, and I'm contracted by the State Office of Rural Health to work on the MB-QIP program, and want to take a moment just to thank Allie Orwig with the Indiana Rural Health Association for supporting Zoom. And also Joyce Fillenworth and David Conrad may not be able to join today because they're helping support the vaccine clinics throughout the state. But Joyce is the State Office of Rural Health Manager, and David is the Flex Coordinator who oversees the MB-QIP project. So we are very honored today to have Dr. Arjun Srinivasan with us from the CDC. As many of you may remember, Dr. Srinivasan has joined us on some webinars about a year ago, and then at a call convening meeting about a year and a half ago. And he has just been a great source of information. He has some excellent videos on the CDC website. But Dr. Srinivasan is the Associate Director for Health-Associated Infection Prevention Programs at the CDC. He oversees several of the CDC's programs aimed at eliminating healthcare-associated infections and improving antibiotic use. I noticed in his signature that he is also the Deputy Lead for Health Resiliency's Working Group, COVID-19 Federal Joint Coordinating Center. So he definitely is a very busy man, and just really pleased that he has taken the time today to provide us an update on antibiotic stewardship and important activities and new best practices. And so without further ado, Dr. Srinivasan, I'll turn it over to you and let you impart your wisdom with the group.
Well, thank you so much, Becky, and thank you for giving me the opportunity to be with you. I'm sorry I can't be with you in person. I so enjoyed getting to meet so many of you when I was able to come up to Indiana in person last time. And so maybe we'll get to do that again next year. But I really appreciate Becky giving me the opportunity to talk to you a little bit about what's going on in stewardship. And I also feel like it's important for me to begin every talk by acknowledging how much I appreciate all of you giving up time today to talk about stewardship. You know, stewardship is a really big part of my job, but I know it's probably a pretty small part of all of your jobs. And the fact that you would give up an hour of your time to come and talk about antibiotic stewardship demonstrates such a tremendous commitment that you all have to patient safety. And I hope you know that I am very appreciative and acknowledge the commitment that you all have made, and hope that today's session will be useful to all of you. We're going to talk a little bit in kind of three different sections. I'll talk a little bit about kind of the most recent updates from what we've learned from our surveys of stewardship programs around the country. I'll talk a little bit about some of the data that we're seeing with respect to what's happening with antibiotic use and resistance during COVID. And I'll close with a couple of ideas on places where I think we can focus our interventions now to be most effective, given the limited bandwidth that all of us have as we try to manage COVID in addition to all of our other responsibilities. Just a brief word to let everybody know that the federal government did update its combating antibiotic resistant bacteria action plan. So this is the national action plan that supports all of the work that we're doing in antibiotic resistance. And you know, the driver for updating that plan and continuing to push in this arena is the data shown here, right? So nearly 3 million infections, nearly 36,000 deaths every year caused by bacteria and fungi that don't respond to the first line antibiotic. So the threat of antibiotic resistance is ever present. I know all of you encounter antibiotic resistance and or Clostridioides difficile almost daily in your practices. So I know this is an issue that you are very well aware of, and it's why you're here today and why we're talking about it. The action plan, like I said, has been updated. There's a new 5-year plan, and you'll note that goal number 1 is slowing the emergence of resistance. And that, of course, is a fundamental goal of antibiotic stewardship. We know that improving the way we use antibiotics can have an impact in delaying the emergence of resistance. And that's why we are so focused on efforts to improve antibiotic use as a key strategy to address antibiotic resistance. We are hoping to invest increase our investments in state and local efforts and at the facility level to prevent antibiotic-resistant bacteria. We want to focus both on preventing healthcare-associated infections and on improving antibiotic use. So like I said, this is what I'll share a little bit, is some highlights from the annual survey that we do of hospitals, and then a quick look at the impact of COVID on antibiotic use and resistance. So we have information, and let's see, move that. There we go. So you can see the full slide here. We have recently analyzed the data from the 2019 survey, and as all of you probably know, because all of you participate in this survey, each year at the start of the year, we send this survey to hospitals and ask them about their practices for the previous year. So this 2019 survey went out in the early part of 2020. We obviously allowed quite a bit more time for folks to complete the survey, given that people were very much in the throes of COVID toward the end of the first quarter of last year. So this is the data that we have from the nearly 5,000 hospitals that report this information. And as you can see, since 2014, we've seen a steady increase in the number and percent of facilities that are implementing all 7 of the CDC's core elements for effective antibiotic stewardship programs. So that is definitely an encouraging rise. And as you can see, we've seen quite a jump in the facilities that have all 7. And for the ones that don't, many of them have 6 of the 7, or even more, 5 or 6 of the 7. So it's really a tiny number of facilities that have very little stewardship activities. Only 107 hospitals in the entire country that have fewer than 4 of the core elements in place. And that, I think, is a fantastic testament to all the work that people have been doing to implement these core elements. I've shown you the overall picture. What does it look like when we begin to break things down into some of the different types of hospitals? And I'll focus here, of course, on critical access hospitals, which I know we have many critical access hospitals represented. And I will tell you with great pride that that is the group, you are the group that has made the most progress in implementing core elements. In 2014, about 20% of critical access, I think it was 23%, of critical access hospitals had all 7 of the core elements. And now you guys are at 79.5%, almost 80%. So a huge increase. You guys have made more and bigger increases than any other group of hospitals. And even looking at the small hospitals, so not just critical access, but hospitals under 50 beds, you can see it's at 82%. So I think a real testament to the fact that this is not just larger hospitals or academic centers that have led this progress. This is progress across the board, and particularly impressive in our smaller hospitals and critical access hospitals. Data here from around the country, just showing the core element uptake by state. You can see that Indiana here at 93%. So you guys have done a tremendously good job across the board at increasing the number of hospitals that have all 7 of the core elements in place, and encouraging to see really, really high numbers in lots of places on this graph. Just showing here the uptake of the individual core elements. So you can see that nearly across the board, we're over 90% for these individual core elements. Of course, we're particularly interested in having multiple and having all of them in place. But again, just showing the tremendous rise and the tremendous progress that we've seen over the past several years. So let me walk you through some of the specific core elements and some of the specific answers to some of the questions, and broken this down here just to specifically show you what we see in kind of overall hospitals and then critical access hospitals in the far column on all of these slides. So this first one is on the priority examples of leadership commitment, right? So these are the things that the facility leadership can do to demonstrate that antibiotic stewardship is a priority and to make sure that the stewardship program has the resources that it needs. And as you can see here, we've seen an increase in the critical access hospitals, but we do still see quite a bit of room for improvement, particularly in the actual tangible support for the leaders of the stewardship program. So the physician leader and or the pharmacist leader actually having stewardship responsibilities written into their contract. So really that in many ways is the most tangible thing that leadership can do, provide the resources for the stewardship leaders. And as you can see across the country, we're only about halfway where we would like to be there, and we do lag a little bit further in critical access hospitals. But what's encouraging to see is that when it comes to allocating information technology resources, which we know can also be very, very helpful, we see that most critical access hospitals have done that. Looking at who leads the programs, we do recommend that the program be co-led by a physician and a pharmacist. And you can see that in most hospitals across the board, in the general acute care hospitals, most places are moving in that direction of a co-led program. 68.5% of hospitals report co-led programs. And you can see in the critical access hospitals, there are some important differences here. The critical access hospitals are roughly evenly split between co-led programs and pharmacist-led programs. And that's something that we have known for quite some time, that there are a lot of pharmacist-led stewardship programs in the critical access hospitals. Although I think we are seeing some growth in the number of programs that are co-led by a physician and a pharmacist, which we think is important. And the reason we think it's important is because we've seen that outcomes can be better with the co-led programs. And this is just one example, that if you look at the programs that are co-led, more of them are likely to have all 7 of the core elements in place. So among the co-led programs, 94% of them have all 7 core elements in place, compared to 89% of the physician-led programs and 87% of the pharmacist-led program. So success across the board here, no doubt, but a little bit better if you're able to have the co-led model for your program. And as you can see, as I mentioned, the co-led model is becoming the predominant model in stewardship programs. This is showing the co-led programs in the orange here. And you've seen that's grown tremendously. Between 2015 and 2019, a nearly 3-fold increase in the percentage of programs that are co-led. So that is definitely encouraging, and that appears to be where things are headed, and that is really great to see. There are some suggestions that folks in the critical access hospital community have about how to implement co-led programs. And this is some information that was shared during a very nice webinar that we did in collaboration with the Federal Office of Rural Health Policy. And these are some suggestions from some of our colleagues, Emily Spivak, who's done a lot of work at stewardship programs in critical access hospitals. And she's said, that the physician leader does not have to be an ID physician. There are other clinical leads, hospitalists, even nurse practitioners who really want to help with stewardship, can be fantastic co-leads for this program. So the key is, finding that clinical practitioner who's willing to partner with the pharmacist in order to be part of a co-led program. The key, of course, is to try and find a way to get some dedicated time and salary support so that these folks actually have the time to devote to stewardship, rather than having stewardship just be, one more burden that they have to manage in addition to their very, very busy clinical practices. With pharmacy expertise, we do see very high uptake. The pharmacists are super engaged across the country, and that's definitely the case for critical access hospitals as well. Some really exceptional critical access pharmacists who are doing amazing work in antibiotic stewardship. And we see many, many examples of that. And many of these pharmacists are accessing a number of different programs that are out there and available for stewardship specific training for general pharmacists. And those I know have been very, very useful to folks. Again, a couple of ideas from Emily Spivak's talk on pharmacists and working with antibiotic stewardship. And again, emphasizing that a pharmacy lead for a stewardship program absolutely doesn't have to be an ID trained pharmacist. That's impossible in most hospitals in the country, especially critical access hospitals. And there's lots of antibiotic stewardship training that's available. So any pharmacist who has the interest, is willing to take a little bit of time, there's lots of training that's available that can really give you the tools that you need to do a tremendous job in infectious disease stewardship. In terms of the priority interventions, what are the actions that people are taking? And we've pulled out 3 that we think have the strongest evidence base. These first 2 Prospective audit and feedback. So this is the stewardship team reviewing courses of therapy that are prescribed and then giving people feedback on the effectiveness of the antibiotics that they've chosen. And then pre-authorization, which is people having to seek permission from the stewardship program before using certain antibiotics. Those two are our focus because there is good evidence from randomized trials that these are highly effective in improving the effectiveness of therapy and reducing treatment failures. So those are the interventions that we think are the most effective. And then we also believe that having facility-specific treatment guidelines is very important because it's important that there's agreement at your hospital on how you're going to treat infections, because that really helps drive all the other interventions. If you have agreement on what the right antibiotics are to use, it becomes very easy then to implement pre-authorization and then prospective audit and feedback, because you can simply compare what people are prescribing to what you have all agreed are the right antibiotics for given infections. You can see here that there's definitely room to grow on the implementation of these leading three interventions. But the great news is that especially with the facility-specific treatment guidelines, critical access hospitals, right where everybody else is, 92%. So lots and lots of hospitals, the vast majority, have implemented facility-specific treatment guidelines. And that's great news, because as I mentioned, I think of that as a first step towards these other interventions. So I'm betting that as these guidelines are now in place, we'll see a lot more uptake and the ability to implement prospective audit and feedback, as well as pre-authorization. Tracking, there are a lot of hospitals that are reporting their antibiotic use data into the National Healthcare Safety Network antibiotic use option. And that, of course, allows you to benchmark your antibiotic use against other hospitals, which is a very, very powerful improvement tool. There are close to 2,000 hospitals that have submitted data into the AU option, including 177 critical access hospitals. And so that has been very exciting for us to see the growth in the uptake in the NHSN antibiotic use option among critical access hospitals. And so that is fantastic. And you can see here in tracking the critical access hospitals, you guys are doing a great job. You're generally right on where most of the rest of the country is with respect to the implementing of the recommended tracking measures. Slightly lower uptake of days of therapy or days present compared to defined daily doses. But again, we're seeing progress and we're seeing movement in the right direction in all of these areas across the board, and including critical access hospitals. Reporting, again, this is reporting back information on antibiotic use and resistance to the practitioners, to members of the hospital. Several different examples that we cite here, and you can see that there is growing uptake across the board of these interventions, including in critical access hospitals. I think what's really good is that when you look at the third one down, the stewardship team providing updates to facility leadership, we see 83% of critical access hospitals doing that. And that, I think, is so important as a first step, because one of the best ways to engage the facility, to engage leadership in supporting stewardship efforts, is to let them know what you're currently doing, what the gaps are, and what your needs are. And we see most critical access hospitals are doing that and beginning to report on some of these other metrics to practitioners. And so that is encouraging to see. And finally, education. We see here, there's pretty good uptake across the board. It's pretty consistent across all the different hospitals. We think there's definitely room for growth here. It's the lowest overall uptake across facility types, although this is growing as well. So I think the more opportunities we have to provide education, the more we get leadership to buy in and support these educational efforts, the more we will see this grow. And hopefully we will get to a point where all providers in the country are getting some sort of informational updates and education on antibiotic use and stewardship at least once a year.
Arjun?
Yes.
I did receive an emailed question to me. Does the CDC have education modules that are appropriate to share with staff to improve education and awareness?
Great question. Yeah, so there's lots of information on our CDC website on antibiotic stewardship, antibiotic use. There are some slide steps up there. There are webinars there. So they are located on the Get Smart or the, I'm sorry, that they've changed the name now. So now it's Be Antibiotics Aware is the website there on the CDC. And if you can't find it, feel free to send me an email, and Becky knows how to reach me. Happy to send you the direct links to all of that information. But yes, thank you for asking that. There's lots to share there. And I, of course, am happy to send slide sets that I've used for talks if those would be useful to you. So please just let us know what you're looking for, and we will help you find it.
Great, thank you.
Yeah. I'm going to shift gears a little bit now and talk about what we've seen. This is some preliminary data of the impact of COVID on antibiotic use and resistance. And for many of these analyses, what we did, or what we have been doing, is comparing what happened in 2019 to what happened in 2020 to try to use 2019 as a baseline, because we obviously did not have COVID in 2019 in our hospitals compared to 2020. And I think this slide is an important background slide because it informs a lot of what I'm going to show you in subsequent slides. And it's that first row that I think is especially important to note. If you look last year at patients who had respiratory illness, so influenza-like illness, which is obviously a very broad category of patients, their mean length of stay was right about 6 days. For patients with a diagnosis of COVID, mean length of stay is almost 2.5 days longer. And as all of you know, that is a very, very big difference. And what that means is that patients who have COVID, at least from this 6-month time period, were much more susceptible to all of the risks that come with prolonged stays in healthcare, particularly with healthcare-associated infections, creating additional risks for antibiotic resistance. And so that is something that is important to note and keep in mind as I show you a little bit of the data on what happened with antibiotic resistance during the COVID pandemic in 2020. So this is the cultures from patients with COVID-19 in 2020 and cultures from patients with influenza-like illness that grew organisms. You can see overall, there was about the same proportion of discharges that had any positive culture. But the difference between whether it was a community onset infection, so an infection that was diagnosed in the first 3 days of the hospital stay, versus a hospital onset infection diagnosed after the 3rd day of hospitalization, some big differences here, right? So the patients with COVID were less likely to have those cultures be positive cultures in the early part of their hospital stay, but much more likely to have a positive culture while they were in the hospital. Again, likely a reflection of the much, much longer length of stay for these patients. Looking at the types of pathogens, we see some interesting differences here. And we're still really working to try to understand what underlies these differences. It's easiest to interpret MRSA and ESBLs because there are larger numbers. These other pathogens, I think it's hard to make much of them because the numbers are so very small. But what you do see here is slightly less MRSA among COVID patients, slightly more among patients with influenza-like illness. And this could reflect the fact that we know there's a pretty strong association between influenza and Staph aureus infections, including MRSA. So that could be what's underlying that infection. And then for ESBLs, we see quite an increase in 2020 among patients with COVID. And again, this could either reflect the fact that ESBLs are oftentimes a healthcare-associated pathogen, and the patients with COVID had longer lengths of stay, or it could reflect some shifting epidemiology and an increase overall in ESBLs. And as many of you might remember from the threats report, antibiotic resistance threat report that we released in 2019, ESBLs were the one category of organisms where we saw the biggest increases. So this could reflect the continuation of that epidemiologic phenomenon. Looking at the sample types, largely what you would expect with MRSA, these mostly came from respiratory and blood samples. For ESBLs, of course, these were overwhelmingly from urine samples, and that didn't differ very much between 2019 and 2020. We did look at the breakdown of the types of pathogens that were recovered for community onset and hospital onset infections. So I'm showing you first here the pathogens that were recovered from the community onset infections. So these were cultures that were obtained at the time of admission or in the first 3 days of the hospital stay. And again, the trends you see here, very consistent with overall. Less MRSA among the patients with COVID, more MRSA among patients with influenza-like illness at the time of admission, community onset infections, and more ESBL, community onset infections, among patients with COVID. The differences are much more pronounced when you look at hospital onset infections. And again, a lot of this is driven by the fact that these COVID patients have much longer length of stay than the patients with influenza-like illness and are therefore susceptible to many, many more of the types of resistant infections that we see in healthcare settings. So here, MRSA, higher among COVID patients, ESBL, much higher among COVID patients. All of this, we think, likely driven by the longer length of stay in patients who had COVID. What about antibiotic use? So I'm going to show you data on hospital antibiotic use first that comes from 2 different data sources. On the top set of panels, this is data from the National Healthcare Safety Network antibiotic use option. That's that module that I mentioned earlier, where we do have about 177 critical access hospitals reporting in. And the data at the bottom is data from the Premier Healthcare Database, which has information from a number of hospitals around the country, about 500 hospitals that report data into this common database. The NHSN data comes from 649 hospitals that were continuous reporters. So they reported data for all these 6 months in 2019 and the same 6 months in 2020. And that's why it's a subset of all of the hospitals that were reporting. It's a subset of about 650 hospitals. And this is aggregate use, right? So this is all the hospitals reporting, and this is all of the total days of therapy summed over all of the total patient days. You can see not major changes here. So use between 2019 in the dark blue and 2020 in the light blue, relatively stable between January and June for 2019 and 2020. This is the same slide format that I'm going to use for the next several slides. So this is all antibiotics. And now I'm going to show you some breakdowns for some individual antibiotics where we do see much more pronounced changes during the COVID pandemic. So this is Ceftriaxone use. And you can see across the board in 2020, it's a little bit higher than it was in 2019. And it's especially pronounced in April. And that, of course, is when we saw that March and April were those big early peak months of the pandemic, the first wave, if you will. And you see in the NHSN data, you see the biggest spike in April. In the Premier data, you see the beginnings of a spike in March and then a bigger spike in April. And those come down in May and June as that first wave begins to subside. The rise is even more striking for azithromycin use. So here you see again in March and April, really big rises in 2020 compared to 2019. So rises in both data sets, but especially pronounced in the Premier data set. And as many of you know, early on, there was enthusiasm for using azithromycin in combination with some other drugs as a potential prophylactic agent against COVID. And so there was, I think, some of this rise reflects some of that use. And some of this rise, like the use in Ceftriaxone, reflects the fact that many patients who come in with COVID present like community-acquired pneumonia. And so they are being treated with Ceftriaxone and azithro for community-acquired pneumonia while providers were trying to figure out exactly what was going on. I'm going to show you 2 agents that are used predominantly for hospital-associated infections, only to make the point that we didn't see much of a change with either of these agents. So this is Vancomycin, and you can see here, not really much change between 2019 and 2020 in either data set. And this is Piperacillin Tazobactam. Again, very, very little difference between 2019 and 2020. So the take-home message, I think, is that we did see some big increases in the use of agents for treating community-acquired pneumonia not surprisingly, during the early part of the COVID pandemic. I'll also show you some information. We have some data from both nursing homes and outpatient settings. This is first the nursing home data. And this is overall antibiotic use. Again, 2019 shown in the dashed light blue line, 2020 shown in the dark blue line. And you can see that generally between January and June of each year, we do see a decrease in antibiotic use as respiratory season ends. That decrease in use was actually more pronounced in 2020 compared to 2019. So a 16% decrease over this time period compared to a 9% decrease. What this is driven by, could this be nursing homes that were closed to new admissions because of COVID or had more discharges because of COVID? We don't know, but we did see a larger than expected decrease in overall antibiotic use. But when you look at the specific agents, it's very interesting that we see almost exactly the same phenomenon that we saw in hospitals. A striking increase in azithromycin use in the March and April timeframe that comes right back down when that first peak goes away, and a very large but somewhat less pronounced rise in ceftriaxone use, again, in that March and April timeframe. So I think the same clinical factor driving antibiotic use in hospitals, also seen in nursing homes. There was a concern about community-acquired pneumonia with many of these patients who were developing acute febrile respiratory illnesses in that March and April timeframe. In antibiotic use, we see big drops in antibiotic use, we think largely driven, of course, by the tremendous decrease in all outpatient visits, right? We know that outpatient visits to doctors' offices, emergency departments, really across the board, dropped dramatically in the early part of the pandemic. And so prescribing, outpatient antibiotic prescribing, drops correspondingly during this time period. So this is all dispense, prescriptions dispensed in 2019 and 2020. And you see this sharp drop off with the pandemic in March and especially in April. Interestingly, azithromycin dropped even more than overall antibiotic use. So this other panel shows azithromycin use, which went down by 62%. So much bigger drops in azithromycin, although consistent with what we saw in the inpatient settings in the New York and New Jersey area, which were, of course, very hard hit by that early phase of the pandemic. We did see higher than seasonally expected azithromycin use in March and April. So where do we focus our efforts now, recognizing that we are all really being pushed to the limit with COVID? Our hospitals are strained, our nursing homes are strained, so we don't have tremendous bandwidth right now. So it really is a time where I think it's important for us to take stock of what we can do to improve antibiotic use and attempt to focus our efforts where they will be most useful. And I think the message is we should focus on what's common. We know that most antibiotics in all acute care settings, so hospitals, but as well as nursing homes, and even in outpatient settings, are predominantly used for just 3 types of infections: lower respiratory tract infections, including pneumonia, urinary tract infections, and skin and soft tissue infections. These 3 infections comprise nearly 3/4 of all antibiotic use in hospitals. And if you look at outpatient settings, you see the same thing, right? Here are all of the respiratory infections in blue, and then skin and soft tissue infections, urinary tract infections. So hospitals, outpatient settings, it's the same things that are driving antibiotic use, which means it's the same targets that we can focus on. Where can we focus our efforts? Obviously, diagnosis is really important, and we definitely saw that with COVID. A lot of times that person coming in who gets labeled as having community-acquired pneumonia doesn't have it. That can be very hard to sort out in the emergency department, but it does remind us that we should revisit our therapy after it's been started. Just because the person is labeled or put on a community-acquired pneumonia pathway, once they get to the floor, you begin to get more information, reassess that therapy, and if they don't have community-acquired pneumonia, we can stop those antibiotics. We can also improve the duration of therapy for community-acquired pneumonia. And this one is important because it sits at that nexus of hospital antibiotic use and outpatient antibiotic use, because most of the therapy that's happening for community-acquired pneumonia actually happens after the patient is discharged, because the average length of stay for a patient with community-acquired pneumonia is about 4 days, but the average length of therapy is closer to 10 days, which means that they're getting a lot of therapy as they are leaving the hospital. And much of that is excess therapy, right? The IDSA guidelines recommend 5 in most cases, and in some cases 7 days of therapy for community-acquired pneumonia. But as you can see here, that across all different age groups, right? So younger patients and patients who have Medicare, so over 65, the length of therapy is more than 7 days in close to 70% of these patients. So there's a lot of room for improvement to shorten that duration of therapy. And shorter therapy means less issues with resistance, fewer issues with side effects for antibiotics. So it's a win-win. We know that from this data, it's a very nice study that was done, that antibiotics prescribed at discharge accounted for 93% of excess duration. So clearly, if we can cut out that excess discharge therapy, we'll have a huge impact on excess durations of therapy. And this has been done in a couple of different studies. In one study, a very simple educational intervention reduced the treatment down from 10 days to 7 days in many, many instances. So some simple interventions can really help us. There's some exciting work that's being done out of Henry Ford Hospital. They've presented some of this work showing that pharmacists can play a really big role in doing that medrec, that reconciliation of the prescription, especially at the time of discharge. So having pharmacists engage at the time of discharge, and in many of those instances, the pharmacists were able to take a look at that chart very quickly and say, hey, this patient has no risk factors requiring a longer duration of therapy. They've already gotten 5 days. They don't even need an outpatient prescription, so we don't need to fill this. And that was a very effective intervention. The pharmacy partners there really were able to drive some big change. Urinary tract infections, or more accurately in hospitalized patients, asymptomatic bacteriuria represents another really important target for us. And again, this is a diagnostic issue, right? So this is not so much treatment, it's diagnosing appropriately. It's not sending a urine culture in those hospitalized patients when there's not a suspicion or a reason for having a urinary tract infection. Having a urinary catheter is not a reason to send a urine culture. We know that most patients who have urinary catheters will have bacteria in their urine. In fact, in some studies, that number approaches 100% after patients have been in the hospital a few days. So if there's no other underlying clinical suspicion of a urinary tract infection, you send that culture and you're faced then with a positive culture result that most providers will look at and feel tempted to treat or pushed to treat because it's staring them in the face. But in most instances, the patients don't need therapy for that simple positive culture without any other clinical findings. And what studies have shown is that if we treat asymptomatic bacteria, we actually do more harm than good for patients. So this is one where our intervention really has to focus not so much on antibiotic stewardship, but on what we call diagnostic stewardship. It's making sure that we're only sending urine cultures when we have a suspicion of a urinary tract infection. And this is a study where they did a very nice intervention where the focus here was to have some a simple algorithm and some questions. They implemented it through an electronic medical record, but it asked providers kind of 3 key questions on signs and symptoms of a urinary tract infection. And if a patient didn't have any signs or symptoms, it said, your patient probably doesn't have a urinary tract infection. Do you really want to send this culture? And most of the times the providers, seeing that data, that information, decided, in fact, not to send the cultures. And what happened is urine culturing went down, and as a result, the overtreatment of asymptomatic bacteriuria went down. It went down not only during the intervention, but that improvement actually persisted after the intervention was over. And finally, skin and soft tissue infections. Again, this is an area where we can focus on diagnosis and on duration of therapy. The guidelines for treatment of skin and soft tissue infections recommend fairly narrow spectrum antibiotics directed against gram-positive organisms, with very, very few indications for broad spectrum therapy, gram-negative therapy, and anti-anaerobic therapy. So here is one where we can really focus providers on picking the antibiotics with the spectrum of therapy that's most appropriate for the intervention and getting that duration down. Most skin and soft tissue infections are treated for longer than is needed. About 7 to 10 days is recommended in most instances, but most people get closer to 2 weeks of antibiotics. And again, here, a very simple intervention focused on education resulted in a reduction in the duration of therapy from 13 days to 10 days, less use of the agents with excessively broad spectrum, and a better use of diagnostic studies. Again, this is just demonstrating that, in most studies that have been done for antibiotic therapy, shorter is better, is equal to, or if not better than longer. This is community-acquired pneumonia. It applies for hospital onset pneumonia and cellulitis. So in all of these instances, if you get a good clinical response, 5 to 7 days of therapy is sufficient. And this has been demonstrated in many, many studies. So I'm going to close, and I think we do have some time for discussion and question and answers. And just will emphasize that COVID is not going anywhere anytime soon. It's taxing us now, and it's going to continue to tax the healthcare system for many, many months to come, unfortunately. COVID is going to exacerbate the long-standing challenges with antibiotic resistance, right? Look at all the things that we're encountering with COVID. Lots of patients with respiratory infections, notoriously difficult to diagnose. Lots of patients with high acuity of illness. Lots of patients with long lengths of stay. And if you were going to create a formula for breeding antibiotic overuse and resistance, boy, those are 3 key things that you would want to include. And there are 3 key challenges that we face with COVID and its interplay with antibiotic resistance. At the same time, even though right now we are so pushed to manage patients with COVID, manage the therapies for COVID, we have to figure out how to maintain some of our antibiotic stewardship work through COVID. We don't want to lose all of the momentum that we gained in the past several years because of COVID. And at the same time, we know that effective antibiotic therapy is just as important in patients with COVID as it is for all of our other patients. Where patients with COVID have bacterial superinfections, those need to be managed effectively. And when they don't have bacterial infections, we don't want them exposed to unnecessary antibiotics. We don't need to create risks for C. diff or for antibiotic resistance. The last thing we want to do is have a patient recover from COVID only to succumb to C. diff or urinary tract infection. And I think the best way to do that is to focus our efforts where they can be most useful. It's the famous quote attributed to the bank robber Willie Sutton. They asked him, right, why do you rob banks? And he said, well, that's where the money is. So in our hospital settings, the money is with the respiratory infections, as well as urinary tract infections and skin and soft tissue infections. But certainly, boy, in the era of COVID, what a great time to double down on our efforts at optimal management of respiratory tract infections, focusing on diagnosis and duration. And we've got time for discussion now, so I would certainly love to know from you what more we can do at CDC to support your efforts to optimize antibiotic use. You are in this day in, day out. You know the things that are most effective, and we would love to focus our efforts on trying to help you in any way that we can. And so with that, I'm gonna stop, and I'm gonna turn it over to Becky for the Q&A session. And if you have questions, please do feel free to put them in the chat. And I'm not sure, Becky, if you also want people to unmute and ask questions in person, however you want to do it. Let me turn it back over to you.
Yeah, I had chatted in earlier. Please feel free to unmute your line and chat in questions. Or I'm gonna move my bar up here. There we go. We did have a question chatted in earlier, and so encouraging everyone to respond to Melissa Toon. But she said, is anyone using CPSI evidence software that is submitting information to NHSN? Reporting to NHSN is a challenge for us. And Melissa, I don't know if you'd like to maybe unmute and share more specifics around the challenge in submitting.
Hi, hello everybody. Thanks, Becky. Can you hear me okay?
Yes.
Yeah.
Okay. We partnered with Century7 a couple of years ago, and we like that platform. We've used it, but CPSI and Evident is our main hospital software. We also have T-System that we use in our emergency department, but the whole point to initially start with Century7 was our infection preventionist at the time had found out that that was going to be our best option to submit to NHSN. However, I'm sorry. However, I'm on COVID vaccine call here, so I have to have my phone on. So
that's fine.
However, we have kind of come to a standstill. We've tried to work with Century7 to give us a partner that they partner with another CPSI evident company to be able to get that information from the EHR into NHSN. And the resource that we've had has just not been responsive to help us. So we're reaching out again to see if someone can help us try to figure out how to get that information, because we're very willing to submit it. I'm just, again, being critical access, we all wear so many different hats, and
Yeah, absolutely.
We have limitations. So any help would be appreciated, and we would be glad to do it.
Well, and Melissa, why don't you, if you want to send me a note after we're done, I would love to try to connect you. You can ask our NHSN folks if they're aware of other folks that are using this particular software package, or if they have any ideas. And we may even be able to find another critical access hospital somewhere that's using the same thing to see if they have any potential solutions. So happy to connect offline.
Perfect. Thank you very much.
You bet.
What other challenges are individuals facing, or want to ask Dr. Srinivasan while we have him on the line? Excuse me.
Be curious to know from all of you if you've been able to continue work that you had started on stewardship. Have you had to stop it altogether? Have you had to scale it back? Have you had to redirect? I know a lot of our pharmacists have been really pulled into remdesivir allocation and monoclonal antibody use allocation. And we've seen a real mix of people who have said, you know, we've been able to continue, or no, we've had to stop. And would love to hear from all of you kind of where you've been on this journey. Have you been able to continue your work? Have you had to redirect some of it? Have you had to stop it altogether?
While we're waiting for that response, I did have a private chat to me, and it's a phone number, so I'm not sure who the individual is, but when you spoke about the education, the question is, did you have a priority order of where you targeted the education to get the best improvement?
You know, that is that's a great question. And it needs to be tailored to your circumstances on the ground. You know, I think that just even talking with providers can be a very good way of understanding, like, well, what do you think the challenges are? Is it pneumonia? Is it asymptomatic bacteria? Is it skin and soft tissue infections? You know, where are we seeing our challenges? And then the great thing is it allows you then to pivot and tailor your education to what the clinicians feel is the great need. So I would really try to drive it that way. And there are many different ways to do it. You can talk to providers. You can pull a handful of charts and just look to see how are people using antibiotics, and how well are they doing with respect to our own facility guidelines or national treatment guidelines, and then tailor your education based on what you see. I think that's generally the most effective way to do it, and it's a really good question.
Another question that I received is, do you have a favorite toolkit that's comprehensive for antibiotic stewardship, either from the CDC or another organization?
Great question. There are a number of them out there. We do have our core elements of antibiotic stewardship programs, and that is reasonably comprehensive and includes a lot of links to other specific guidance documents and implementation documents. So that is a great, I think, primary resource to use because it's got so many other connections, and it's of course available fully free of charge on the CDC website. There are, the IDSA, SHEA, and the Pediatric Infectious Disease Society have guidelines. The American Society for Health System Pharmacists has really good stewardship guidelines. But, as an initial starting point, I think the core elements documents is a really, really good place to begin.
Okay, good, good. And we'll send the links to those and other key links from the CDC website. Cindy McCammett did share that they have scaled back on antibiotic stewardship due to needs with COVID infusion center and COVID vaccine clinic. Any good suggestions on making sure that antibiotic stewardship's not put too far on the back burner?
I think it's tough. I wish I had a magic bullet solution there, but there are only so many hours in the day, and there are only so many of all of you to go around. So I think this is reality. It would be silly to say, just keep doing stewardship and ignore all that other stuff. These are the priorities right now. So I think we do the best we can. And the key for me is kind of what I talked about is, if you have that little sliver of stewardship bandwidth left, try to focus it on an area where you think you have the most opportunity for improvement, whatever that is. But I think the respiratory infections are a good one to focus on because it does dovetail nicely with COVID.
Another chatted comment was, enhanced isolation efforts, education, tracking, reporting updates, and staffing for COVID has definitely redirected a lot of our limited resources.
Absolutely.
And, yeah.
Yep. Yeah, very, very true.
Yeah. Do the best you can with what you have.
That's exactly right.
What other questions or comments from everybody out there today? I know you're all working extremely hard and covering vaccine clinics and really wearing more than just multi hats, just almost a multicolored hat that's spinning on your head. So.
Hi, Becky, it's Melissa again. I'll just comment. I want to thank you all for this presentation today. It kind of gives you a second to come back into focus on what we need to be looking at. I know at our next antibiotic stewardship meeting, we're going to bring the core elements back, look at those again so we can try to refocus some of our time on that. We have seen an uptick in, and I discussed this with my region too on our quarterly phone call, the last call that we had. We've seen an uptick in using Rocephin and Azithromycin, and just to be honest, whenever we're having that discussion in our region, one of the comments was made that physicians feel like they need to be doing something, so that's what they're using. And again, I think that's an area that we can focus for improvement, and just reiterate the information that we've received today, and just try to make sure that we're watching those patients closely, and being able to have the tools to step up and help us to say, no, we don't necessarily need those antibiotics. But that is a challenge because I think physicians' hands are tied and they feel like they need to be doing something. Unfortunately, it may not be the right thing to be doing. So
I think that's very, very well said.
So Arjun, are you seeing a lot of hospitals going back and kind of reviewing some of the, I guess for lack of a better term, basics of infection prevention with staff, just to review, reiterate, and not lose any ground that they've already gained?
Yes, there's been a lot of that. And COVID did provide a good opportunity, if you will, for a lot of our infection prevention programs to, really get in and reinforce compliance with isolation, hand hygiene, all of those types of basic infection control measures. And as Melissa pointed out, it's also a really good time to reinforce, just because you have fever and a cough doesn't mean that you have bacterial pneumonia. And so, let's think about what people have and work to move our prescribing accordingly, recognizing that things, of course, change, right? So you can come in with COVID pneumonia and then develop something else, but COVID pneumonia doesn't respond to ceftriaxone and azithromycin, and so we should do our best not to use it in situations where it's not needed.
I was chatted a question. Do you have recommendations on education for families? And I guess I'll add in even patients. Do you have some favorites that are out there on the CDC website?
We do. In fact, this was a great point that someone raised, is that we needed something for hospitalized patients. There's some fairly good resources for outpatients, for clinics, about antibiotics and cough and cold, bacterial infections versus non. But we didn't have anything for hospitals, and we do now have a fact sheet, a handout. I think it's called "You've been prescribed an antibiotic, so now what?" And it's focused on patients, and it helps them understand. You should know what you're getting. You should know why you're getting it. You should know how long you're going to get it for. So it gives them, empowers them with, these are the questions that you should ask. And then it also helps people know these are the things you need to watch out for and tell your team about. If you get diarrhea, even after your antibiotic stops, you need to let us know, because you could have C. diff. So it's a very kind of, it's a patient-oriented resource, family-oriented resource, and that's available on the CDC website.
Great, thank you. I'm not seeing any more questions
Great.
or comments in the queue right now. We definitely, today's session was recorded, so feel free to share that with others in your hospitals. We will provide the link to that core elements toolkit that's comprehensive that was mentioned, as well as some of the education modules. And if you have any other questions or any other concerns, or want to share more details around challenges that you're having with NHSN, let us know and we will facilitate getting some help and some answers back to you. So thank you so much, Dr. Srinivasan. As always, you're a wealth of knowledge, and I appreciate you taking out time for Indiana. And hopefully you can come back in person again sometime. And
I hope so.
Yes. And really appreciate everyone joining today. We know how extremely busy you are, and we do appreciate everything that you're doing every day. Stay
Indeed.
safe and stay in touch. Thank you.
Thank you, everyone.